Hello, everyone. Welcome to TEPHI's Infection Prevention 105 module titled National Healthcare Safety Network, the NHSN. Before we begin, I would like to briefly introduce what TEPHI is. The Texas Epidemic Public Health Institute, TEPHI, works to keep Texans safe and the Texas economy strong by preparing Texas for the next infectious disease outbreak. If you're interested in learning more about TEPHI, we have a few QR codes at the end of this module that can guide you to different resources. My name is Oluwatoyin Akanji, and I am part of the Small Rural Healthcare Systems program at TEPHI. I graduated from Brown University with dual degrees in biology and health sciences, and I have experience providing infection prevention education to the community. The second presenter today is Kayla Ruch. She's an infection prevention practitioner who is certified in public health, healthcare accreditation process, and infection prevention and control. During the pandemic, she had the opportunity to work in an acute care hospital in Texas, long-term and skilled nursing facilities in New York, and acute care hospitals in California before returning to UTHealth to pursue a Ph.D. in epidemiology with a concentration in infection prevention and control. The learning objectives of this module are to describe and explain National Healthcare Safety Network, which is the NHSN, to describe and explain central line associated bloodstream infections, which are known as CLABSIs, to describe and explain catheter-associated urinary tract infections, known as CAUTIs, and lastly, to describe and explain surgical site infections, also known as SSIs. Before we get started, I would like to mention a disclaimer. During this presentation, we'll be discussing a few graphic pictures during the CAUTI and the SSI sections. And these pictures are used to describe the infections that can occur due to surgical procedures, urinary catheters, or central line devices. In the previous module, we discussed HAI and surveillance programs. We said that about 1 in 31 hospital patients had at least one HAI on any given day in the United States. Healthcare-associated infections are a top concern for infection preventionists, nursing and medical staff, and all other departments in the hospital. The hospital's primary goal is always to provide a safer environment for patients and provide the best type of care without causing any patient harm. However, sometimes patients develop infections in healthcare settings that are related to process breakdowns, opportunistic organisms, lack of resources, or cleaning sterilization processes. The National Healthcare Safety Network, which is the NHSN, is a surveillance system that is used by nearly all infection preventionists across the country to report and track nosocomial infections. NHSN provides facilities, states, and regional centers with data needed to identify infection prevention issues, measure the progress of prevention efforts, and provide guidance to report events with the ultimate goal of eliminating HAIs in the country. A significant component of an effective IPC program is determining if an infection meets the NHSN criteria to decide whether it is an HAI. Infection preventionists will spend a large portion of time reviewing the NHSN case definitions and infection timeline to determine if the infection meets the specific criteria of an HAI as stated in the NHSN manual. The patient safety component includes 5 modules that focus on events associated with medical devices, surgical procedures, antimicrobial agents that are used during healthcare, and multi-drug resistant organisms. The NHSN safety manual is updated annually for healthcare systems to use, and the rest of this module will briefly introduce a few chapters of the manual. So the annual facility survey. At the start of every year, every facility should complete a facility survey that tracks infection prevention data from the previous year. Different types of facilities, whether it be general hospitals, women or children hospitals, have different survey components. Make sure to complete the appropriate annual survey for your type of facility. And this survey should be completed before March 1st. And if not done by then, you cannot submit the monthly report. So patient safety monthly reporting plan. Facilities contribute monthly data on various patient safety metrics, such as HAIs, adverse medication events, and other patient safety data. These data can be categorized as in-plan surveillance or off-plan surveillance. In-plan surveillance means that the facility follows the entire NHSN surveillance protocol for an incident. This type of surveillance data should be submitted to the Center for Medicare and Medicaid Services, the CMS, and it can be used in NHSN annual reports or other NHSN publications. Off-plan surveillance means that just when a facility decides to keep track of a specific event for their own use, for the facility's use, and if it is marked as off-plan, it should not be indicated in the NHSN, in the annual surveys that you submit. So now the rest of the model, I'll hand it over to Kayla. Thank you.
Great, Toyin. Thank you so much for that start of the presentation. As Toyin mentioned, the reason why that we are talking about surveillance plans is that all healthcare-associated infections are required to be reported to NHSN. So it is very important that you conduct your surveillance survey, develop your plan, and within that, based on your facility type and the service lines, along with your staff and your patient population, you will be allowed or expected to have a certain number of healthcare-associated infections based on this survey. So it's very important that you complete the survey accurately and correctly, which kind of gives you the level of HAIs that you should expect throughout the year. The goal is always to be under than expected and never to be over. So that's just some view background of why that we're talking about surveillance in the plans. Now we're going to jump into and talk specifically about healthcare-associated infections, your workup flow, look at NHSN definitions for some of them, and this is just a brief overview. There's a lot more material for these things, and we're going to reference back the NHSN manual, which is linked at the end of the slides, for you to go back and look through. It's a very long, lengthy manual, as you saw on a previous slide, and we're only going to touch on a couple of the mini chapters. But overall, when you do your healthcare-associated infection workup, you first want to start with your date of event, which then affects your infection period window, your IWP, and then you want to look at your location of attribution, aka what unit was the infection on, and then you'll go into your HAI specific criteria, and in this module we'll talk about CLABSI, CAUTI, and SSI. So the first in the workflow is looking at the date of the event, and that is the date of the first element used that determines the NHSN site-specific infection during that 7-day window period, which is your infection period window. This date of event is critical because this will help you determine if it's POA, which is present on admission, or known as community acquired, or if this is healthcare associated HAI. HAI definitions happen on day 3 of hospitalization. It is not a certain time, as in 24 hours, 48 hours, or 72 hours after being admitted, but on the calendar day. So on the 3rd day at 12:01, on that 3rd day, that is when we are now in the HAI realm, compared to day 2 and prior, we're on the POA realm. So then after you determine your date of event, that will also help you determine your infection period window, the location of attribution, what device is associated, when that device was plated, and then it'll also start your day 1 of the repeat infection time frame. So what is the repeat infection time frame? So after your date of event is determined, it will start your 14-day time frame that no other infection in that same pathway can be developed. So here's kind of an example of this when you look at the chart. As you see on day 4, we have our first clinical indicator of an infection, which is a urinary culture. And then it sets, as you see, the blacked out for the next 14 days of that infection is present. On day, in that 14-day period, on day 9 or on day 12 of the hospitalization, you can see that another urinary culture is obtained, and it's a different organism. So you still follow the same infection from that day 1 of the 14-day windows, or on day 4 was it E. coli, that If it meets a UTI or a CAUTI definition, it will stay within that 14 days. It's not eligible for a second CAUTI infection until after that 14 days, so starting on day 15 or on day 18 of hospitalization in this example. So next you go into, after your date of event, determine what that is of setting your infection period window. And that is a 7-day window where all site-specific criteria needs to be met. That means that the NHSN definition for that specific infection needs to be set within that 7-day window. And you kind of do, the date of the event is in the center, as you see here on the chart, and then there's 3-day prior and 3-day after, and that's how you monitor it. And to set your date of event, it could be a laboratory specimen collection, it could be an imaging or procedure or an exam. And we'll go through some examples of that next. And this specifically applies to CAUTI and CLABSI. SSI is its own different workup and surveillance because it's a surgery. And we'll talk about more of that in that section. So just some things to be mindful when you're setting your infection period window. You don't need a diagnostic test to set the window. It could be any new sign and symptom. So when you are reviewing the patient's chart or a chief complaint, when they come in, you are looking at the first diagnosis. Patient is saying that I'm experiencing fever, I'm experiencing cough, I'm experiencing drainage. That could be your first sign and symptom of that infection. You're not waiting necessarily for that diagnostic test, which is an imaging, a culture, a specific vital sign. You can have that documentation. And then also within this time period, one or more criteria can be met. So it doesn't have to be all the things, or if they're having multiple signs and symptoms, it's at least one sign and symptoms is met. And we'll go through an example next. So here's kind of an example of when you're looking at your infection period window and kind of determining POA versus HAI. So first in option 1, as you see, and just as to explain, POA is present on admission, IWP is infection period window, and then healthcare associated is HAI. So in example 1, or in option 1, that you see that the minus dates represents prior to being admitted. Day 1 is when patient comes into the hospital. And then day 2, as you see in option 1, new onset of cough. So now patient has been admitted, they're on an inpatient location, and they are presenting now with a cough that they did not previously have. So that is our first sign and symptom. The next day, on day 3, now we have an imaging, which has diagnostics of infiltrates. And then we have on day 4 more symptomology, and then day 5, day 6 as well, to look at a specific definition. In this example, it's looking at pneumonia, which is another workup, but it kind of just shows you the flow. Compared to option 2, which is the incorrect way of that, not acknowledging that first signs and symptoms, but you're using your diagnostic test to set your HAI criteria. So in option 2, you look at, see how they're starting their window or the date of the event as on day 3, which now it's healthcare associated, compared to on day 2, that's community acquired or POA. So it can make a big difference. So that's why it's really important to look at the notes along with your diagnostic testing so that you accurately represent when the infection is happening. And this is really important because HAIs are a big financial burden onto the facility, and CMS requires the facility to cover that. So when you are reporting these things, not only it's at the facility level, but in NHSN, which falls under the CDC, as we previously talked about, it's on the national level too. So you want to make sure that you are diagnosing and using the criteria correctly so that you're accurately reporting what's going on in your facility. And then here's just kind of another thing of looking at your date of event, setting your window, another POA on day 2, the first symptomology on example 1 is that fever. This is now a diagnostic test, but the first one is on day 2, which is meaning POA, as I've previously have stated, compared to an example 2, then it's HAI, which is on day 3 and further on in the admission stay. And during this time, these POA and HAI determinations, they also have to be in an inpatient location too. So this symptomology needs to be documented and seen on an inpatient location, as in not the ER, not in triage, but an actual unit into the facility. So it gets a little bit more complicated too. And that's also why when you're looking at date of event, you need to see where they are and making sure that they're on the inpatient side and they're not in the ER, or if they're in an outpatient clinic or anything like that. That is also very specific to the HAI workup as well. So then the next important thing is determining what location is responsible for this, or the location attribution. And so that's basically saying what location or what group could have potentially led to this healthcare-associated event occurring. Sometimes in the facility, patients can move around a lot based on patient flow, triage, bed available, staffing as well. And NHSN takes that into accountability, and they specifically have what is called the transfer rule, which is when you're looking at HAI data and event, you want to look at where they were the day before, the morning of the day before that event occurs. So we'll go through an example next to it, but it's basically the first location the day prior to your date of event. So in example 1, you see that patient is on unit A on 3/22, 3/23 they're on A and B, and then on 3/24, which now they're having symptomology and NHSN definition has met, it's been set as your date of event. So you want to look at the day before, which is on the 23rd, and then the morning of that. So that's unit A. So that's why the location of attribution is unit A, because it's the day before, that morning, that's who's responsible for it. Example 2 kind of shows where there's multiple units involved on multiple days again. So you want to look at the day of event is on 3/24. You see that it's on unit C and D, but again, you go the day prior and that morning of, so unit A. Not B, not C, not D, but unit A. Especially when patients are moved around a lot, you definitely want to go back to your bed tracing and see where the patient flows. You're correctly identifying where the patient was that this infection occurred. So now we've kind of done the background work that kind of helps you set your date of event, your infection period window, where they are on that date. And now we're going to go see what NHSN HAI definition is met based on that. So you want to do all that preliminary work before going into your criteria. And even as a seasoned infection preventionist, I have my manual with me all the time. I pull it up, I highlight it, I review it just to make sure that we are correctly identifying and we're saying that it truly is an infection. So the first infection that we're going to talk about today is a central line associated bloodstream infection, or CLABSI, and this is NHSN Chapter 4. And as we've mentioned in the beginning, this is just a brief introduction. There's a lot more material. NHSN puts out great YouTube videos that are hour-long on each chapter, giving examples, workup, that are really great references for you to go on and explore. So central line associated bloodstream, why is this so important? One, this is when a systemic infection or a bloodstream infection has occurred in the patient, and this can due to procedure breakdown, opportunistic organism, lack of supplies, multiple things. And the reason why this is so important is that this can lead to patient mortality and also has a financial cost that falls back onto the facility. So we definitely want to work through proper insertion techniques and management of central line, along with training and educating our patient and our staff about the risk of having a central line. So what is a central line? A central line is any intravascular catheter that terminates close or close to the heart in one of the great vessels that we have. And it also is used for infusion with blood draws and hemodynamic monitoring. And here's just a couple examples of what central lines are. So there's central lines, and then there's also peripheral lines. They're kind of, if you've been a patient before, if anything that you see in your hand or just that is a very superficial line, that's not what we're talking about. We're talking about the bigger lines that are more invasive, that are terminating close to our heart, and that have more effect on our hemodynamic monitoring. And here's just some examples of common ones that you'll see in the facility. And as on the picture, common ones are your PICC lines, which are your forearms, your subclavian one, that's under your clavicle, your interjugular one was up on your neck, and then you'll also have your femoral, which will be down in your groin too. So with the central lines, then we're looking at determining if there's a primary bloodstream infection or a BSI or a secondary. For this lecture, we're going to concentrate more on the primary bloodstream infections, which means that there's no other secondary cause to the infection. It's specifically from the line, compared to a secondary bloodstream infection could be from a wound or something in the GI or another location where there's infection and now it has spread to the bloodstream. So again, today we're just going to work on primary bloodstream infections. And so what is the overall CLABSI criteria? And it is one, to have a central line, which is on that list that I previously showed, and that it needs to be in more than 2 consecutive calendar days. Therefore, on day 3 of that central line being used and accessed, they are now eligible for CLABSI definition. And then the second thing is that it is an eligible BSI or bloodstream infection organism. There are certain organisms that NHSN deems to be allowed and some that are excluded. So when you're working that up, you're also making sure that it is an appropriate organism that NHSN recognizes. And then lastly, putting it all together, that for a CLABSI, you have a laboratory confirmed infection where an eligible organism that for a bloodstream infection has been identified, which the eligible central line is pleasant and has been accessed and has been in for more than 2 days. And we'll kind of work through more of the definitions and then give some examples at the end. So for CLABSI 1, it's a very cut and dry definition. The patient has an eligible line that we saw. It has been in more than 2 days, and then that it has a recognized bacteria, not including the common commensal, but not on that list, but still another eligible organism. And then it is related to no other site as an infection. So you have the line, it's been in for 2 days, and now you have an organism that's not on the common commensal, but the regular NHSN CLABSI list. So there is CLABSIs 1, 2, and 3 as we've seen, and when you are reviewing them with the hierarchy, you always want to report CLABSI 1, and then 2, then 3 in the hierarchy order. And for CLABSI 1, you don't need any other signs and symptoms. They have a line and they have an eligible organism, and that line has been in for over 2 days, and that's it. They might not have a systemic infection yet, aka showing signs and symptoms of fever, hypertension, anything like that. But as you see in this picture, you might see at the line side where you see, here's just a graphic of the picture, there is some redness, or it's raised, or it might be warm. Sometimes the redness, depending on the skin tone, might be really easy to be seen, and sometimes it won't be able to be seen. So keep that in mind. Just because you have, the line does not show outer signs of infection doesn't mean that it's not infected too. So not all central lines, when you go in and observe the patient, you're going to see this drastic redness around the line, but it is something to be mindful when you are assessing them and when you're talking to the nursing staff as well. So then our next CLABSI definition is CLABSI 2, which is a patient of any other age, and now they have become symptomatic. So they have a fever over 38.0 Celsius or 100.4, they have chills, they have hypertension, they have an organism in their blood through a blood draw culture that is not related to any other site, and now we have that organism is a common commensal, which is a naturally occurring organism that can be found. For example, staph is a common commensal. We naturally have it on our skin. And this definition really takes account into blood draw contamination. So that's why it says for point 3 that you need 2 or more blood specimens collected on separate dates. So this will help determine that it's a true infection and it's not an actual blood contamination due to the blood draw and not prepping the skin appropriately before you have drawn the blood. So you need, and for this definition, you need that organism to be the same in both blood draw specimens. So if you have a staph species and then maybe a candida species in the second one, no, they're both common commensals. It has not, your definition hasn't been met. And that kind of goes into our notes that it needs to be within that 7-day period, that with our date of event being in the center, with that 3 days forward and 3 days back, and that for point 2, it needs to be a matching common commensal. So it needs to be the same exact species that is in both blood draws on 2 separate occasions to be meeting this. If you are working it up and you just have it's on one, but then the next blood draw that you're doing 4 hours later, it's clean and there's no bacteria present, you can more talk about that. This could possibly be a contamination, and refer to your lab folks to ask about it. How was the blood drawn, and go forward there. And then if at this point, if there's still any suspicion, you could order another blood draw to confirm that, no, this patient truly does not have an infection, or maybe it does. That is something to be mindful of. And then also with antibiotic stewardship, if the patient has received any antibiotics or a loading dose of antibiotics with a blood draw, that can affect your bacterial growth rate when you're looking at these as well. And then for point 3, you need a specific element, a sign, a symptom of infection, which is that chills, that fever, that hypotension. So then the next CLABSI is for more of our pediatric patients are under 1 year old. They're symptomatic. Their organism is eligible. It's not related to any other infection. And then now it's a common commensal. So same thing as what we just talked to, but now the only difference between CLABSI 2 and CLABSI 3 is an age requirement. And then same thing, it needs to be within that 7-day period window, 3 days before, 3 days after, and then that organism has to be matching in both blood draws. And here's just kind of another example of what like some redness can look at when you're looking at the specific site. So you can see that there's redness from that they're starting to show signs and symptoms of infection. Now we're just going to go kind of into some examples of when you are eligible or not. Because sometimes with central lines, it's really tough to see when it started, when it stopped, when it's accessed, how long it's been in, and it can get kind of confusing. So our first example, we're going to talk about a patient that has come in with a port. So the patient has been admitted, as you see on 3/31, a port has been in, but it is not accessed. And anytime when a patient comes in with a device from the outside, you always want to see documentation of like, hey, they do have a central line, but you also need to pay attention when it's accessed. Just because that there's documentation there does not necessarily mean that it's accessed, and you need to follow up with your nursing clinical folks of when we're actually accessing that port, because that's what starts your eligibility. So you see on 3/31, the port's in, but it's not accessed, so it's not eligible for a CLABSI. Same on the 1st, and then on April 2nd, now it is being accessed, so now it's eligible on day 1. So now we're on day 1, and then 3/3 is day 2, 3/4 is day 4. So now we're eligible that port has been in for more than 2 calendar days and has been accessed. Even though it's been in the whole time, it's that it has now been accessed at that time on calendar 3, which now on calendar day 3, which makes it eligible for a healthcare-associated infection. And then it's de-accessed that day. So it's been accessed and then de-accessed that day. So then we follow it for 2 more days after it's de-accessed. So central lines are eligible 2 days prior after being de-accessed or removed. So you see then it's eligible for CLABSI definition on April 5th and April 6th. So then here, kind of the same thing, another example that you have a port central line in on 3/31, not accessed on the 4th. Our eligibility starts on April 2nd. It has been accessed. Now we need 2 days after. So on 3/3 has been accessed, it's not eligible. And then 3/4, now it's been accessed for more than 2 calendar days. So now it's eligible, but it's removed. So we have it being eligible for CLABSI definition on 4/4, 4/5, but on 4/6, now it's been 2 calendar days after it's been removed. It is no longer eligible for CLABSI definition and workup. Okay, here's another example where we have lines in and out being placed and removed, which is very common. We see this sometimes when patients start to get better, then we remove the lines and then they decompensate, so then we need better access and we're putting back in lines or maybe different lines. So on 3/3, the central line's in. It has been in now for a couple days, so it is eligible. On 4/1, still eligible. On 4/2, it has now been removed, still eligible. And then, so on 4/2, the line comes out. So part of that day, they don't have the line. And then on 4/3, another line is put in. And so that still makes them eligible. And then 4/4, they're still eligible. And during this time, there hasn't been a disruption of the central line being removed or the patient without a central line for more than 2 calendar days. So your eligibility is still maintained over the time period, even though it's 2 separate lines. To break up the eligibility, you need that line to be removed more than for 2 calendar days. And then our last example, you'll see where it's removed, a line put in, removed. As you see on 3/3, a line's in, it's eligible. 4/1, 4/2, it's removed. 4/3 is the second day, and then 4/4, they are no longer eligible, but now we have a new line in. So then now we're starting over the clock. They're not eligible on 4/4, 4/5, but on 4/6, now it's been more 2 calendar days, they are now eligible again. So you can stop and start your clock many different times when you're looking at eligibility for CLABSIs, and that just kind of makes it confusing. So that's the tricky part of the definition of making sure that it's a primary infection and then that line has been in place, or if there's multiple lines, when it was accessed, when it started and stopped, and when it was removed too. So now we're going to go into our second HAI that we're going to talk to today, and it's catheter-associated infections, or CAUTIs, which is NHSN Chapter 7. CAUTIs are a big problem along in the United States and in healthcare in general. And a lot of times our urinary catheters are placed for specific needs, just like our central lines. However, it is statistically increased our risk of infection, of getting a urinary tract infection related to a catheter, the longer the catheter is in place. So after 4 days, compared to 5 days, there is an increased risk of 5 days, and then on the 6th day, there's another increase of risk of it developing. So the longer it is, the more risky it is. So the types of catheters that we have, which is our indwelling or our internal catheters, and that is a drainage tube that's inserted into the bladder through the urethra, left in place so that we can drain the contents of our bladders. There are a lot of times called Foley catheters, which is a brand. They can be used intermittently or continuous. There are external catheters, which are known as condom catheters or straight in and out catheters that do not qualify for the HAI definition because it's an external device. It's just kind of there, and then it's out. Compared to an indwelling device, it is staying put for multiple days. Also, nastrostomy tubes, ideal conduits, and suprapubic catheters, since that is a surgical device that is placed, they also do not meet the eligibility for CAUTI surveillance as well. So making sure that you're documenting that it's a suprapubic catheter, which is a surgical catheter, compared to an indwelling catheter is really important because one is eligible and one is not. So the CAUTI criteria is that, same with central line, a catheter-associated indwelling catheter has to be presented for at least 2 consecutive calendar days, and that is eligible on the day that it's on day 3, and then the day after it's removed too, just like we saw with central line. So it has to at least be in for 2 days, and then once it is removed, it is eligible for CAUTI surveillance on that day and the following day as well. And here's just kind of a picture of what a catheter looking fill, and you can kind of see that the urine looks kind of cloudy, which also can be concerning at that time, usually shows signs of infection. So there's 2 types of CAUTIs, and the first criteria is a symptomatic UTI-A or SUTI-A. So for this criteria, the patient needs to have an indwelling catheter for more than 2 consecutive days, or it has been in for 2 consecutive days and then we're removing it on that day or the next day and monitoring. They have one of the signs of symptoms. They have a fever of over 38 degrees Celsius or 100.4 Fahrenheit. There's suprapubic tenderness, or there's costovertebral pain. And these are starred because there needs to be no other reason why this patient is having tender and pain in this area. If you are doing surveillance in, for example, if your patient has now had a C-section and she's recovering and she has a urinary catheter, you can't clinically say with definitive evidence that that pain is related to the catheter. It could have been related to just giving birth, having a surgery, or a surgical procedure. So with those 2 areas, it has to be related to specifically the catheter and no other cause or symptoms. If they've had surgery, if they've gone through a trauma event, nothing like that. And then for urinary urgency, frequency, and dysuria, which is pain, well, urination, those signs and symptoms are after the Foley has been removed, because you can't really assess urgency when you have a device placed in your bladder. So those 3 criteria is after the Foley is removed, then you're monitoring that day and the next day. And then the last criteria is that a patient has a urinary culture no more than 2 organisms with a bacterial count of 100,000 CFUs per milliliter. And then for SUTI-2, the only difference is now that there's an age. These are for our pediatric patients, younger 1. For 2, there's symptomology. Again, with the STARD, it can't be related to anything else, specifically that just the device, maybe not how they're delivered, or if they've gone through trauma or any other event. And then same with the culture, it has to be greater or equal to 100 milliliter CFUs for your bacterial count. And some exclusionary things to be paying attention to. Mixed flora is not acceptable to NHSN. It can have 2 species, and that's it. If it's 3 or more, it is excluded, doesn't meet criteria. It needs to, that culture also needs to have a CFU of over 100,000 CFUs per milliliter. If it's lower, doesn't meet the criteria, doesn't meet CAUTI definition. And then for point 3, it is not an excluded organism such as Candida. Candida can naturally be found in the urogenital tract, so therefore it is an exclusion because you can't really say with definitive evidence that this is an infection. This could just be their part of their natural flora, along with parasites and fungus. And then for points 4, 5, and 6, that documentation needs to be specific. So we need specific language, as you've seen here. It can't just be generalized pain. NHSN wants very specific language in the documentation, so they want specific words to be used. And then here's just kind of an overview of how you do your CAUTI workup. You first, when you're doing surveillance, of identifying if this could be symptomatic or asymptomatic. And then you break it down to the culture result. Is it less or more than 100,000 CFUs per milliliter? If it's less than, doesn't meet CAUTI, you can stop right there, doesn't meet the criteria. If it's more than 100,000, then you move on to the next thing. Has this patient had a indwelling catheter greater than 2 calendar days or not? If it hasn't been in for more 2 calendar days, doesn't meet CAUTI definition. If it has, then you move on to the next step, which is then looking at that signs and symptomology. And if it is within the criteria that we looked at, then yes, it's CAUTI. If it's not, no, it's not. No CAUTI is present. And then here's just a quick example. So we have a patient admitted on 325 who's 65-year-old, admitted to acute care hospital for trauma, admitted to ICU, and a urinary catheter is inserted. On 26, it's in place. 27, it's in place. On 28, they remove it at 7 a.m. However, later in the afternoon at 1 p.m., they start complaining of urinary frequency, of having to get up and void multiple times. The next day, on 329, no fever. On 330, they have an elevated count of their white blood cells. And then on 3-1, then we are ordering a culture of their urine, and it is showing a culture count of over 100,000 CFUs per milliliters of E. coli. So in order, as you can see, our date of event, which is the first day that they are presenting with symptomology, which is on 328, which is highlighted in green. You have your infection period window, which is 3 days prior and 3 days post, which is highlighted in blue. Your LOA, which is your what location, it's ICU, hasn't been moved around. You see that in the note. And through this, we are now looking at the criteria for CAUTI. Yes, the urinary catheter has been placed for more than 2 days. They have symptomology, and the culture count has counted. So therefore, yes, this patient now has experienced a CAUTI. And now the last section that we're going to briefly talk about is surgical site infections, or NHSN Chapter 9. Surgical site infections are still a big issue, and a lot of times NHSN and CMS expect a certain level of surgical site infections to occur. So that's also why it's so important to adequately look at your NHSN survey and monthly reporting, because that data of how you report will also help calculate it, which is your SSI standard infection ratio, or your SEER. So they are expecting, based on your patient population and your service lines, to have X amount of infections and X amount of your procedures become infected, just due to opportunistic organisms and just like statistical probability. The goal is always to be at or below this year. You never want to be above this year, which really shows that, you know, maybe there's a gap in practices, or there's an opportunity to improve things. And then your SEER is also a nationally recognized benchmark that you can compare facility to facility, but make sure that you're looking at your specific facility, comparing it to the other specific facility, aka acute care to acute care versus, you know, a critical access hospital to a critical access hospital. And so for each state, there are different surgical procedures that are monitored. For Texas, we just monitored 2, which is your abdominal hysterectomies and your colon surgeries, as you can see here. And we look at the inpatient setting, and our surveillance period is for 30 days. One note, if you have a wound classification coded as clean for your colon, you have to exclude that one. The colon is a naturally dirty organ. There are good bacteria in that help with our fecal mass breakdown and absorbing nutrition, which is appropriate. However, regardless of the surgery, that organ's never going to be clean, so it cannot be coded as a clean procedure. If it is, it's excluded. An example of a clean organism would be your heart. There's never normally bacteria within that organ, so that would be what a clean procedure or any type of heart-related surgeries. So then when you are filling out your surgical site reporting information, you are collecting the following information: your ASS score, your diabetes, operations duration, looking at all the things here. They are specific risk factors for infections occurring, diabetes, if it's trauma, if it's emergent, your wound class, and then looking at your PATOS definition. And this is a great way to track and trend some things. This is what's required to be reported to NHSN when you're entering a surgical site infection. Something to also maybe add at the facility level is what surgeon and surgical team are doing these procedures, so that you can track and trend if there is an issue with a specific surgeon, or also with a scope, looking at your scope procedures in case if you need to go back to your high-level disinfection or sterilization auditing that, hey, this device, there always seems to be a surgical site infection occurring. You can go back and look at it and follow up with other people in high-level disinfection and sterilization too. So one thing that as it looks at is PATOS. And what is PATOS? PATOS is an infection presented at time of surgery, aka that patient, when you cut them open, already have an infection. However, NHSN is very specific with the documentation and the language that needs to be within that chart. Overall, in the intra or the peri-op or intra-op or post-op, they don't recognize documentation of colon perforation, contamination, none of the things highlighted in yellow. They want purulent drainage, abscess, pus, and then also they expect, if that's what you see at time of cut, you are also taking a sample and sending it to the lab to culture it to make sure that good antibiotic stewardship is on board as well. So they're looking at both of those things for PATO's determination. Trauma won't guarantee you that wound class of PATOs just because someone's had a traumatic event, say a motor vehicle accident, doesn't necessarily indicate that there is a sign of infection at time of cut. So it's a whole other thing, but they're wanting those other risk factors to know of what kind of is representative of our surgical patients. And there's 3 different criteria of surgical site infections. We have our superficial, our deep, and our organ. So both on the colo and histo, you're monitoring those, and then out of those surgeries, then you're classifying what level of infection, which is superficial, deep, and organ space, and each one of them has its own definition that we'll briefly go over. So for superficial, that's within your first 30 days, and that is only your skin involvement. So that's really seen just on the topical on the site, and you can see purulent drainage. Then that organism is collected, swabbed, tested. You can also have documentation from a physician's note. Imaging really doesn't play a part in this realm because it is that superficial. It should just be that top layer of skin. And this is kind of what this is looking like. So it's looking, as you see on the picture of a surgical site, that you're seeing this redness and inflammation. You can, kind of go in and see. And at that point, then maybe they're opening up. Depending on your surgeon, what they want to do, maybe giving antibiotics topically or just orally, doing any imaging to see if it's a deeper infection or what layer it's in, or just treating it superficial. For surgeries, there always are going to be either categorized as your primary or your secondary. For the 2 surgeries that we monitor in Texas, we will only ever have primary. Secondary are surgeries that require 2 sites, or if you're grafting something, sometimes when you're taking vasculature from one area and then grafting onto another organism, that's where your secondary infection comes in, of looking at the graft site versus the organ that it's presenting on, such as a CBGB, which is a cardiac procedure. But for these 2, it's just a primary. Some exclusion, they're not just accepting the word cellulitis, or if it's just one lone stitch that may have like a little bit of redness, just like a little pocket at one stitch. It needs to be the whole thing that we saw in the previous slide. That whole area needs to be superficial. Also, if there's like any stab wound or a pin site of infection as well, doesn't qualify as an SSI superficial infection. Our next infection is our deep, which is in your 30 or 90 days, which makes more sense. The deeper the layer internal cavity, it needs longer to grow and to show infections. It involves your soft tissue at this point, and then also that you're having 0.3, that there's purulent drainage. We need to now go in and aspirate and probably do a washout of this tube. We're not going to be able just to give oral antibiotics or intravenous, but we're going to have to go in and do a second procedure as well. You can also look in your intra-op notes of seeing when the physician opens up that previous surgeries, scar, if they're seeing any abscess, fluid, anything like that, or dehiscence as well, that will qualify. Then it's also taking a culture, sending it for analysis that that bacteria is not usually within that pathway. And then also the patient is having some symptomology too, since it is a deeper infection. They will now be symptomatic at some point of having pain, fever, tenderness, or absence of an abscess or pus or anything like that on that gross atomic exam, aka reopening them up and you're seeing pus there. Again, For our 2 category, we only do primary. This is kind of an example where you can see more of a deeper infection. See how it goes past just the topical skin that you now see that's more in the soft tissue here on this picture. And then our last infections are deep organ space, and that is all the way deep, a very deep, serious infection. It goes 30 days and beyond. It is now in our muscle fascia, maybe in our open organ area. And this is where you're going to, both your deep and your organ space infections, you might see those on imaging. So when you're doing the MRI or ultrasound, you're seeing fluid, you're seeing murky fluid, and then when they're going in and doing surgical intervention, you are seeing pus, purulent drainage. You're also obtaining that for culture, doing a washout, and then cross-referencing it that the appropriate antibiotics are present. So we're following that good antibiotic steward program that we've set. And then lastly, just like anything else, there's exclusionary organism. Some organisms, regardless of the how the procedure is going, they will not occur. And that's kind of our parasites that are more like atypical organisms, which you see kind of listed here. Those aren't commonly found on people in surgical areas, and the likelihood of a patient being exposed to this due to procedure breakdown or sterilization process breakdown is really uncommon and when it really happens. So they do look at that. If you're ever experiencing an atypical organism or you think it's atypical, go back to that NHSN list. Both NHSN, the common commensal and the regular non-common commensal is very extensive. It is a huge spreadsheet of all the organisms that qualify. So definitely my recommendation is to download both those lists along with your NHSN manual and print out your NHS manual, look over and look at it. Also making sure that there is evidence of if it has been POA, with that PATOS definition, it's there and it's still being reported. Anything that falls under the PATOS category, you're still reporting it to NHSN, but that does not affect your SEER rate that we talked about. And then lastly, when there are multiple levels of infection, say if you have superficial versus deep versus organ space, you are always going to report the deepest level of infection, which is going to be that organ space, because that's the most severe infection for it. So I know this was a lot of material and everything. Again, this is just a brief introduction. Definitely download your NHSN manual and go over it, and I'll turn it back over to Toyin for the last little bit of our lecture.
So today we have introduced information about the NHSN. We briefly talked about healthcare systems. Our NHSN provides healthcare systems with guidance to track infection prevention data and measure progress of prevention efforts. We also talked about CLABSIs, CAUTIs, and SSI and how they have extensive epidemiology definitions to determine if HAI occurs. So as Kayla said, this is just a brief overview, but the NHSN manual is extensive, so it takes time, knowledge, and practice to learn and understand the manual. These are our references that we used in the slides. We have a quick announcement before we move on to the questions. Immediately after the lecture, post-survey evaluation we sent out. You can also scan this QR code for the survey. We greatly appreciate your feedback, and you can, in the survey, you can enter your email for a chance to win a free swag. We invite you to come connect with us. You can email our team at tephi.texas.gov or info@tephi.texas.gov and follow us on the following social media platforms. The model slide deck will be posted on TEPHI's YouTube channel after the presentation. Thank you very much for your attention and for attending today's lecture. We'll now open it up for questions.
And just one more thing, we just want to thank you all for connecting with us, coming to our modules. This has been year one. If you haven't been able to come to our previous modules, there's 4 other ones before this. Check out our TEPHI YouTube page to watch our Our PowerPoints are available, but we're here to serve you and help you. So definitely if you can take that survey and put in what other material you would like to have us cover, we greatly appreciate the feedback. So now we'll just open it up for questions.
Kayla, are you able to see the question?
No.
Okay. Would you kindly explain if the patient has a suprapubic catheter and is positive for infection, whether it is reportable?
So for a CAUTI definition, if they have a suprapubic as in a surgical invasive device, no. For the NHSN definition, that is excluded. So that's why it's always important when you're reviewing a patient's chart to make sure if this is an internal or external or a surgical device. So if they have a suprapubic catheter with the NHSN definition, they do not qualify, as you see me here. Yes, here. Great question. I mean, if they are at that time, say if that suprapubic catheter has now become infected and they're having chronic infections, then I would maybe check with the surgical team or the attending for that patient to discuss that, because once that system is infected and that surgical device is infected, this is going to be a recurrent problem. So maybe now taking them to surgery and removing that might be an option, but again, I would check with urology or maybe renal to see what the action should be most appropriately for that patient.
Okay, and I don't know if this is the full question, but it says, can you further explain gross anatomic? I don't know if that's...
So gross anatomic is meaning, that's more in your pathology report. That's kind of what that's looking at. So when you're collecting samples and you're reviewing it, it's sent off to pathology. So say for surgery, the surgeon is in the surgery, they see the pus. But at that point, then they are collecting a sample and then they're sending it over to pathology. And now the pathology will do a report on it. They'll also do a sensitivity. They'll look at under the microscope. This could be a gram stain. This could be a tissue culture. There's going to be a MIC report, which is your sensitivity. And so that's where it falls under that gross anatomical, is that what you're seeing and reviewing at the time. So it kind of depends on what you're looking at specifically, but that's what that's more in reference to. Great question.
Okay. Is there any colostomy site infection?
So a colostomy can become well, I guess it depends. So that's a great question. Long and short, it's a tricky answer. It depends on with your colostomy. Is this a new colostomy, old colostomy? Did this colon procedure say they had the colostomy and then within the 30 days it's infected? Then yes, it would go under the colon procedure within your 30 days of your surveillance. If this is a non-new colostomy, say this patient has had a colostomy for 6 months, a year, and the colostomy or the stoma site is infection, that's a whole different workup, and you could work it up looking at Chapter 7 of NHSN, which are other infections. Because there are multiple infections that you can have. You can have a skin infection, you can have a GI infection. There are different categories of GI infections. There's a whole other chapter that looks at other type of infections. So when you're doing your surveillance, really looking at the time frame, when it was done, does it fall in within that surveillance of that 30, 60, 90 day, and then working it up then. That colostomy could be infected and that they might have to go in surgically, cut more or redefine it, but it may or may not be under the colo surveillance, just depending on those factors. Great question. I know it's not a straightforward answer.
And it looks like that is all we have in the chat.
Oh, great. Well, thank you all so much for connecting with us. Please take that survey at the end and provide us, what topics do you want us to cover next year? And thank you so much.